ठीक है. So I think, sir, we have just completed.
Yes, yes,
We will
excellent.
gradually come out and we will put a few surgicals more on the wall, and then we will remove this
Yes, yes. And you also
saline.
show where is the dura and where is the
Okay, sir.
brain margin,
Okay.
just to show them the sufficient decompression.
Yes.
Usually when you do good decompression, then the brain is much
Fatty
away
तैयार
from the
रखना
dura
ऊपर.
matter.
बैठी बैठी तैयार रखना ऊपर. कई बार है ना ऊपर से वो ऊज आ जाता है. लाओ इधर थोड़ा और सर्जी से लगा के फिर बाहर आ जाता है. लाओ हल्का सा एक ये ले आ, बस छोटा सा. बस
सर, सर, प्रोफेसर कपूर सर, सर, बैठिए, बैठिए सर.
चल हटाओ.
प्रोफेसर खोसला सर, प्रोफेसर कपूर सर, हाँ,
सर आ गए.
प्रोफेसर वीपी सिंह
तीन
सर,
सर तो नहीं आ गए. चलो सलाइन दे दो.
सर,
फैटी आउट हो गए.
एक्सडी इन मेडिकल कॉलेज,
बगल से डालना
हेड
धीरे
ऑफ
धीरे. हाँ
डिपार्टमेंट ऑफ
बढ़िया.
सर्जरी.
सही है. अब इसको थोड़ा ऊंचा करते हैं. ले बस बस. सर्जी सेल और तैयार है ना, उससे रख देंगे अपन धीरे धीरे उससे, है ना. लाओ सर्जी सेल लो हल्का सा यहाँ दे, जल्दी दे. फिर एक पैटी दे देना. माइक्रोवूज हैं छोटी छोटी. ठीक है. एक और दे दे छोटा सा है? नहीं वूज ही है हल्की सी. हाँ ला एक पट्टी अब दे दो बस. ऊपर ऊपर रख देते. छोटी दे दे. हाँ बस. आई गया. ठीक. अच्छा एक मिनट रुक, इसको पूरे ही निकाल देता हूँ. आउट हो गया. अच्छा ये ड्यूरा और ब्रेन दिखा देते हैं सर. हाँ अभी लगा. सो सर दिस इज द वी आर शोइंग दिस द ड्यूरा एंड दिस इज द ब्रेन. यू कैन सी. थोड़ा डिजूम कर ले. ये
यस सर, ड्यूरा हेयर एंड द
डिजूम
ब्रेन.
कर दे.
लेटरल थोड़ा टेढ़ा
थोड़ा-
करोगे ना
करता हूँ सर.
तब
हाँ
तब
लूज
थोड़ा
कर.
और अच्छा दिखेगा.
डिजूम कर दे.
ठीक है सर, गुड डिकम्प्रेशन.
सो दिस इज द सर. एक मिनट थोड़ा अंदर जाता हूँ. यू कैन सी दिस इज सर.
Yeah, so
This is fall of brain there.
brain is quite significantly away. So good
So
decompression.
we will do now hemostasis of the surface.
This is for those people who think that
Yeah,
decompressive craniotomy is required. This is not required.
Then a pen,
If you do good this thing, then it is fine. But at times, if you see the edema is out of proportion, in those cases, some cases after surgery you find lot of edema. In
Patty
that
निकालना.
case, very rare, in less than even not
ऊपर से रख
1% may require decompressive.
Saline डाल देना.
I mean, you can go in again and take out. So, I think hardly 3-4 cases in my lifetime required decompressive
Sure.
bone
Saline
removal
done.
after doing endoscopic surgery. So good hemostasis and yeah,
So I put this saline.
complete
This is clear.
hematoma removal.
अब अच्छे से ऊपर वो लग दे सर्जी से, है ना. अच्छे से ऊपर देखो यूज यूज.
ठीक
So
है.
we are closing now, sir. After
Okay,
doing some hemostasis.
you come quickly
Yes, sir. Yes, sir. Yes.
downstairs.
Yes, thank you. Sir.
Okay, Jitin.
Sound check. Check, check, check.
Hello. Hello. Shall I start? Good morning, everyone. Respected Professor J.P. Kapoor, sir, our ex-dean of the Medical College, Professor V.K. Khosla, sir, uh, Professor V.P. Singh, sir, Professor Y.R. Yadav, sir, Director, ex-director of Super Specialty Hospital, Professor Arjun Saxena, sir, Dr. Ashish Tandon, sir, Professor Hitesh Gurjar, faculty and staff of NSCB Medical College. It is with immense pleasure that we welcome you to the 29th Neuroendoscopy Fellowship Program at NSCB Medical College, Jabalpur. We are also extremely thankful to you for attending this event. This program, which was started in 2009, has successfully trained more than 1100 neurosurgeons until now. We had trainees from every part of the country and also from abroad, including Germany, Italy, Iraq, Malaysia, Sri Lanka, Nepal, Bangladesh, Jordan, etc. We thank everyone for making this program a great success. I request Dr. Dhruv to felicitate Professor Kapoor, sir, with the yes. Take picture. Yes, I request Ratre sir to welcome Professor VP Singh sir and Professor VK Khosla sir. I request Ratre sir to welcome Professor Saxena sir and Tandon sir. Please welcome Tandon sir. Please welcome Dr. Hitesh Gurjar sir. I request Malika ma'am to welcome Khosla madam. I warmly welcome everyone here. I now invite Professor Vaya Yadav sir to say welcome address.
Respected Kapoor sir, Professor J.P. Kapoor, ex-Dean Medical College and Head of Department of Surgery. Professor Kapoor sir basically started neurosurgery in this medical college. When I came here, Professor Kapoor was Dean and HOD of surgery, and he allowed me to work, practice neurosurgery in NSCB Medical College, because when I came here, this was only, there was no neurosurgery department. So for 16 years I worked in general surgery, and this is because of sir and subsequent general surgery department who helped us to grow. Thank you, sir. Professor Khosla sir, he is my teacher, my mentor and everything. Thank you, sir. Thank you for coming. Madam Khosla, madam, thank you for coming. We are grateful. Professor VP Singh sir, today I am standing here because of him. I think some of you may not know, he revived me when I had cardiac issue. Thank you, sir, and he is the orator. Thank you, I am grateful, sir. Professor Arjun Saxena is my friend. Thank you, Arjun. Thank you, Dr. Ashish Tandon. He is a great neurosurgeon and endoscopic surgeon, plus he has a workshop in April. So very nice workshop. I think those who wants to learn endoscopy should attend every workshop in India or abroad also, but at least in India, because going and attending one or two workshop is not enough. So thank you, Ashish. I also welcome Professor Hitesh. He is professor at AIMS Delhi. Thank you, Hitesh, for coming and gracing and helping us. I welcome Professor Aparna. She is professor of neuroradiology. So you will be happy to know that here in Jabalpur we have a school of excellence in which we have neuroradiology, neuroanesthesia, neuropathology. All branches are working in one place. So we are grateful to our teachers, and obviously I also welcome the delegates, and I'm thankful to the whole surgery department for asking me to come, and this workshop is very close to my heart. This workshop is designed very well. We discuss about the case selection, indication of surgery, contraindication. So for any good results in surgery, you should know when to operate, when not to operate, indication and contraindication. We also discuss the technical nuances, and you can see the skill. So and after the live workshop, there is simulation models in the evening, and then cadaver, hands-on cadaver dissection. So I think all of you should take full advantage of this. Thank you very much. Thanks.
Thank you, sir. I request Dr. Mukesh Sharma to please come forward and welcome Professor Aparna Tamaskar, Madam, Head of the Department, Neuroanesthesia. I request Khosla, sir, to give few words of blessings.
Good morning, everyone. Professor Kapoor, Professor V.P. Singh, Professor Yadav, and other members of the entire team. ऐसे मौके पर क्या कहें क्या ना कहें, एक कशिश ही हो जाती है। करीब 30 साल पहले पीजीआई छोड़ा था, हमने तो शायद कुछ किया नहीं, सिर्फ इसको एक रोड टैक्स दे दिया था, ये टैक्स हो, भरते जाओ, अपनी पगडंडी खुद ढूंढो। He belongs to Rajasthan and तो देखिए अपने प्रदेश को छोड़ के दूसरे देश में आ गया। यहाँ पर एक छोटी सी पगडंडी पे चलता रहा। जहाँ तक मुझे ज्ञान है ठोकरें भी खाई और वो जरूरी भी है। पैरों में चोटें खाई, कांटे चुभे, लेकिन उसने अपनी पगडंडी छोड़ी नहीं। जरूरी नहीं कि किसी को एक खुली सड़क मिल जाए, पगडंडी पे चल के ही आपको अपनी सड़क बनानी पड़ती है, अपना रास्ता बनाना पड़ता है। इसके बाद तो मंजिल की क्या कमाल की आपको सामने ना आए। छोटी से पगडंडी पे चला, हर पत्थर हर ईंट को अपना रास्ता बनाया, उस रास्ते को पक्का बनाया, साथी जुड़ते गए, कारवां होता गया, एक छोटी सी पगडंडी एक रास्ता बन गया। और अगर आज आप देखते हो, एक ये ऑर्डिनरी रास्ता नहीं है, आम रास्ता नहीं है, एक ये नेशनल हाईवे बन गया है। और उसमें सिर्फ हिंदुस्तान के सफर करने वाले लोग नहीं हैं, बाहर से भी लोग आए हुए हैं जो रेगुलरली यहाँ पर आते हैं। इससे बड़ा और प्रमाण क्या हो सकता है प्रोफेसर यादव की हार्ड वर्किंग का। अब इतना बड़ा ये नेशनल हाईवे बन गया है कि एवरीबॉडी वांट्स टू कम इन एंड जॉइन। मंजिलें एक पड़ाव, उसके बाद में मंजिल दूसरी, फिर और पड़ाव, उसके बाद मंजिल तीसरी। मंजिलों की कोई कमी नहीं, क्योंकि रास्ता तो अब बन गया है। इस पर याद आता है एक गुरु और शिष्य का क्या बंधन होता है। हमें गुरु कहलाया जाता है, लेकिन हम पता नहीं हम गुरु हैं कि नहीं। गुरु कौन है? जो किसी को कुछ सिखाने की चेष्टा करता है। और शिष्य कौन है? जो सीखने का प्रयत्न करता है। बस यही मात्र डेफिनेशन है, सिखाना और सीखना। यही नॉलेज है, यही शिक्षा है। कभी कोई शिष्य बन जाता है, कभी कोई गुरु बन जाता है। मुझे तो नहीं लगता कि मैंने इसको कभी कुछ सिखाया था, और ये बात तो पक्की है कि मैंने इसको इतना नहीं सिखाया है जितना ये अब मुझे सिखा रहा है। तो सीखना सिखाना ये परंपरा चलती रहती है। एक अच्छा शिष्य वही होता है जो सीख पाता है, और मेरे हिसाब से एक अच्छा गुरु वही होता है जो जिंदगी भर सीखता रहता है। जिसने सीखना बंद कर दिया, ना वो शिष्य रहता है, ना वो गुरु रहता है। यही दोनों का बंधन है, इसमें और कोई तीसरी जगह नहीं है। ये चक्र यूं ही चलता रहेगा। कभी कोई गुरु बन जाता है, कभी शिष्य बन जाता है, कभी वही शिष्य आगे जाके गुरु बन जाता है। यही हमारी सोच है। इसी के साथ पूरा एकेडमिक वर्ल्ड यूं ही चलता रहता है। आज हम यहाँ इकट्ठे हुए हैं प्रोफेसर वीपी सिंह का लेक्चर सुनने के लिए, और मैं बेसब्री से इंतजार कर रहा हूं कि मैं उससे भी कुछ सीख पाऊं। पहले सोचेंगे, सीखेंगे, तभी आगे बढ़ेंगे। जिंदगी में चलते रहना चाहिए। आपकी स्पीड कितनी है उससे कोई फर्क नहीं पड़ता है, लेकिन जब आप रुक जाओगे तब आप वहीं ठहर जाओगे। चलते रहोगे, कभी तेज हो जाओगे, कभी धीरे हो जाओगे, लेकिन चलते तो रहोगे। आपके और वीपी सिंह के बीच में अब मैं नहीं आऊंगा। हम सब इंतजार करते हैं बेसब्री से उस स्टिमुलस का, क्योंकि वीपी सिंह को मैंने पहले भी सुना है। ही स्पीक्स वेरी वेल। यू विल अप्रिशिएट हिज कॉन्फिडेंस. You will appreciate the choice of his good quality words. He doesn't waste his words. Good quality words, properly placed, with full confidence and a clear message. I hope all of you enjoy that. I hope I take back some lessons to move forward. I thank Professor Yadav and his entire team for getting me down once again here and trying to learn something more from this get-together. Thank you very much, and I wish the whole organization a big success. Thank you.
Thank you, sir, for your kind words of blessings. We can now start the oration program. I request Kapoor sir to chair the session. Be seated there only, sir. I request Ratre sir to come forward and give a short introduction of Professor V.K. Khosla sir, on which the oration program is named.
Good afternoon, everybody. It is a matter of great honor and pride for me to introduce respected Khosla sir, because sir is the teacher of our teacher, and sir is a very great teacher and a very nice human being. Sir needs no introduction, but as a part of this oration, I will present a short introduction of sir. Sir is the former head of Department of Neurosurgery, PGI Institute of Medical Education, Chandigarh. Sir was excellent, has excellent school records, has done MBBS and MS from Andhra University, MCH from PGI Chandigarh in 1977, MNA MS in 1986, done diploma in skull-based surgery from Osaka City, University, Japan in January 1992, and FICS from Nagoya University, Japan. Sir has many awards under his name. He was first in pharmacology in university. He has many international awards, Best Poster Award in Annual Conference of Japan Neurosurgery Society, Japan 1991. Many national awards, is visiting faculties to Department of Neurosurgery of Osaka City Medical College, Japan, Nagoya University, Nagoya, Fujita Health University, Japan, and he was honorary fellowship for contributions in neurosurgery from International College of Surgeons. Sir is visiting faculty for many premier institute of our country like All India Institute of Medical Sciences, New Delhi, Nizam Institute of Medical Sciences, Hyderabad, CMC. Sir examiners for MCH from all the premier institutes of India. He is on editorial board of Neurology India, India Journal of Pain, Indian Journal of Neurotrauma. Sir has delivered many prestigious orations like Presidential Oration of NSI Lucknow 2009, Oration at Medical College Visakhapatnam, Shri Shargvir Singh Oration RNT Medical College Udaipur. Sir is academic members like life membership of NSI, members of various societies of international as well as national societies. Sir is office bearer in academic professional societies like Sir remain the president.
As is concerned, Professor Khosla, I had come to you for 15 days from AIMS, and you were the head then, and I saw your keen interest in skull base and Petrus approaches. I used to watch you in those days when I was there at PGI, so thank you so much, sir. To quickly begin about Professor V.P. Singh, sir, who is currently the chairman at the Institute of Neurosciences, Medanta, at Gurgaon, Delhi. And this is his initial pictures, though I'm not able to identify you, sir, to him or here. So are you here or here? I'm really sorry. So, sirs, he comes from a very sort of family who's into academics. His father was a professor at and he was teaching anthropology. His mother is a homemaker. He has two brothers for a 6-year program in 1987 at AIMS itself, and thereafter he completed his DNB as well. Prior to joining AIMS and during his stint there, he worked as a neurosurgeon at St. Stephen's as well as Lucknow. He was a visiting fellow at Newcastle General Hospital, where he sort of focused on aneurysm surgery. He was also a visiting fellow at Sheffield Gamma Knife Center. From 93 to 98, he worked as an assistant professor in neurosurgery, additional professor in neurosurgery at AIMS 98 to 2002, where sort of I came in contact with him and worked under him. And he was a unit head then when I was there at AIMS. Thereafter, it was sad for all of us. Though he shifted from AIMS, he moved to Women's, and he was not only looking after neurosurgery but Gamma Knife at Women's, and thereafter he worked at Indraprastha Apollo, and currently, as I mentioned, he's working as the chairman of Institute of Neurosciences, which has almost 13 to 14 neurosurgeons in the team, and about 7 to 8 neurologists, and it's a great department there. He has 3 to 4 DNB students, so he's actively involved in academics at Medanta as well. He is selected as best student for academic excellence at AIMS. He has multiple best papers. He has a diploma of merit from Asian Conference of Neurological Surgeons, and he has more than 70 scientific papers and book chapters. Well, there's no doubt, sorry, that he has great leadership skills, and sort of he's able to inspire a lot of juniors to sort of excel in their fields. He was president of NSI 2122, President of Indian Society of Pediatric Neurosurgery from 23 to 25, as well as President Cerebrovascular Society 16-17. He also looked after as Secretary of Neurological Society of India between 2014 and 17. He represented NSI to the President. This is one of the photographs showing that. He has, because of his keen interest, he had other posts as well, including that of the editor of Journal of Pediatric Neurosurgery from 2009 to 2015. He was executive committee members in multiple national societies. He's given a lot of prestigious orations and lectures, presidential oration at ISS FNS Mumbai, Sir Geoffrey Jefferson Lecture at UK, NSI President Lecture, CNS San Francisco, T.S. Kanaka Oration Chennai, multiple national and international orations, and we are extremely fortunate and happy to have you here for this oration as well, sir. His area of special interest is pediatric neurosurgery, neuro-oncology, epilepsy surgery, cerebrovascular and radiosurgery. He is one of the pioneers of epilepsy surgery in India, and he brought in hemispherotomy and various other surgeries to AIIMS while he was there and sort of developed the program. He has major role in advancing gamma knife in the country. He is a mentor to generation of neurosurgeons, and we are all so fortunate to have worked along with him. He has a strong and great clinical leadership. What it doesn't say is that he is a great administrator as well as the as far as the department is concerned, because in him, under him, you have a no-nonsense sort of approach, and a disciplinarian, a hard task master, but then he has an extremely soft corner for his students. As far as family is concerned, ma'am, Mrs. Latika Singh, he got married in 1998. She is a PhD working in DU in English literature. His son Ishan, he has done computer graphics and is currently working in US. He is now blessed with a granddaughter who's 8 months old. His daughter Anahat, she is working as a oncology clinical psychologist again in US. So every mountain has a great story. Professor V.P. Singh, sir, is amongst us here. He would be sharing his knowledge and experience as far as neural tube defects is concerned, role of folate. Once again, sir, it's a great opportunity to have you at Jabalpur. Thank you for joining us here. Thank you so much.
Hello. Thank you very much, sir. I request Ratre sir to please welcome Dean sir. I request all dignitaries on the dais to please come forward for lamp lighting. Sir, please come forward.
शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा
Thank you very much, sir. I request Dean sir to say a few words. Shoes. Good morning, everyone. On this occasion of 26th neuroendoscopic workshop, first of all, I welcome the orator, Professor Singh, and the iconic figure as was just listening, Dr. Khosla from PGI. In fact, it's being a pleasure to be here amongst these all stalwarts of the neurosurgery. And our friend, he has started this neuroendoscopic workshop, Professor Yadav, and good friend of mine, Dr. Arjun, who is the head of the Department of Surgery in Suksagar Medical College. And all those young budding neurosurgeon of the country. I am here from 97 in this college. And I have been in touch with Yadav sir for a long time. In my previous schedule of dean or period, you can say 17 to 19, me and Yadav sir struggled a lot to start this center, neurosurgery center. And we traveled many times to meet our principal secretaries and ACAs and minister, and many times. So we had very good fond memories to start this institution. I'm really proud of everyone, and I think let's give a very round of applause for the Yadav sir making this institution at the national level recognition. And he was the president of this neurosurgical society, and he's represented India in US recently. So in fact, just to a message to the young neurosurgeon. See, I'm also a surgeon. I'm a ophthalmologist. So there was a caption in the book Love and Bailey. I think everybody has read Love and Bailey in the surgery. And there was a interesting bottom line written in the bottom line, the caption, good one. So I remember the caption was written, big surgeons give big incision. There was a caption, big surgeons give big incision. But in the contemporary situation, in this situation, bigger the surgeon, smaller the incision. I am an ophthalmologist, so we started with the 1.5 degree of 180 degree of the cornea. Now we are sub 2. Sub 2 means 2 millimeter, less than 2 millimeters. So fine incision. So it has been a very great journey from that to this side. And all of you are now, everybody is going for endoscopic surgery, and we have a good support of the anatomy department, so you can go and practice endoscopy there. And really it has given a very good management skill. Now the coming of, I think 5 years down the line,
maybe robotic surgery, everyone has a robot, and so it's a world-changing world. So I congratulate Professor Head Shalin and Director of Super Specialty Hospital Avdesh and Superintendent Dr. Jiten and our whole team, Jitin, everyone. I mean, so it's a normal feature of this department. Means if you don't go for, I mean, we will ask why you're not going this year. So it's a routine. It's become a benchmark, and it becomes the mandatory feature of my institution. So I'm very much proud of the neurosurgery department doing a wonderful job and involving all the budding neurosurgeons of the country. So all the best. Thank you very much.
Thank you very much, sir. I request Malika ma'am to felicitate Professor Avdesh Kushwaha, sir, Director of the Super Specialty, and Professor Dr. Jiten Gupta, sir, Superintendent of the Super Specialty. Now I request Professor V.P. Singh, sir, to come forward and give us talks.
Good morning, everybody. Professor Kapoor, dignitaries on the dais, friends. I must thank Professor Yadav and his team for calling me here, inviting me, and asking me to give this oration, which is an honor and a privilege for me. Professor Khosla was inspired into neurosurgery by the legendary Professor Ban Parmeshwar Rao at Visakhapatnam Medical College, where he studied. He had his neurosurgical training at PGI and then joined as a faculty. He was one of the first people to do a formal fellowship in skull-based surgery under Dr. Hakuba, who was very renowned. He is a pioneer in anterior cervical spine surgery, and he had many innovative techniques devised by him. His expertise in modeling the bone grafts to fit into the disc spaces perfectly and fix it to the adjacent vertebra with thin steel wires is something which only he could have envisaged and made. And post-corpectomy, he would use a K-wire to form the scaffolding around which the acrylic implant was used. All very, very innovative. And at a time when cadaveric dissections were not common, he practiced in cadavers before doing the first transoral odontotectomy in North India. My first interaction with him was when he came to AIIMS to give the exam. I was a resident at that time, and my God, we were all scared of him. He was so strict in his demeanor and hawk-eyed. He would pick up the smallest of mistakes that you do. But he was methodical and meticulous in his work and in his surgery. Perfection in everything he does, and a great surgical acumen. He is a passionate teacher who would inspire and motivate his students. A shrewd administrator who knew how to get the best out of each subordinate, how to sort of see what is good in a person and how he could use that to make the department go forward. And many of these qualities you can see reflected in this picture. He is a man of few words, but he can effectively communicate without antagonizing the other person. I am honored and privileged to be giving this oration in his name and in his presence. Thank you, sir. The topic I have chosen is not a neurosurgery topic. I'm not going to be talking about surgeries or the number of cases I've done. This is something I'm very passionate about. I mean, as surgeons, you change lives, you touch lives, you help families. But no matter how good a surgeon you are, there's only a finite amount of number of cases that you can do. At this stage, I think we have to go beyond it and try to help the society. And that is why I've chosen this topic, neural tube defects, the role of folic acid, and a call for action in India from all of you. So if we look at the under 5 mortality in India, it is reduced from 22.5% in 1950 to 3.26% in 2020. Remarkable achievement. The common causes are listed here, and all of these we've been able to tackle except congenital birth defects. And now we need to focus on preventing birth defects to the extent possible. And there are a fairly large number of them. The prevalence in India is 6 to 7%, which means 1.7 million birth defects every year in babies who are born in India. And the common ones are congenital heart disease, congenital deafness, and neuron tube defects. So this is the outline of my presentation. I'm going to take you through the neuron tube defects, what we know about them, how we can prevent them, and what we should do, and where we are at the moment. So during development of the fetus, the neuron crest folds on itself and fuses to form the neuron tube, which gives rise to the brain and the spinal cord. And all this process is completed in 28 days of conception. By this time, the lady may not even be aware that she is pregnant. And any anomaly in this process results in neuron tube defects. So this occurs very early in gestation, by the 4th week of conception. And this is the variety of neuron tube defects which can happen depending on the degree of abnormality. A common one which all of us see are the spina bifida, the meningomyelocele. There's a swelling in the back. There may be paralysis of the limbs, loss of bladder bowel dysfunction. There may be hydrocephalus and foot deformities. And this is what we see, the swellings, the foot deformities, and the hydrocephalus. And the important thing is, what God hasn't made, we can't make. So there is no cure for neuron tube defects. These patients need lifelong medical care. What are the outcomes? Almost all children with anencephaly are either stillborn or die soon after birth. But even patients with spina bifida, it depends on your degree of care. In the US, mortality is 15% by 5 years. In UK, it was 35%, 1/3 of these people die. In low medical income countries, the mortality is much, much higher. And those who survive are left with a lifelong disability. How common are they in India? 324,000 babies are born around the world with neuron tube defects. And Southeast Asian region is fairly involved. In this region, India has the highest prevalence. If we include stillbirths, the incidence is even much higher. So coming specifically to India, we have studies available, and the Pune prevalence is 4.5 per 1,000 total births. This is in patients here. Another study, meta-analysis with more than 8 lakh children born, the prevalence rates was 4.8 per 1,000 births. And there are enough studies to say that it is fairly common. The incidence varies from 6 to 8 per 1,000 live births, and this is the latest paper from 2024 where the prevalence has been as high as 9.46 per 1,000 live births. Now, nutritional factors have been suspected to be responsible for neuron tube defects for a very long time. But it was this landmark study from the Medical Research Council group in 1991, which was a randomized study which conclusively proved that of the four arms which were randomized, 2 of them who received folic acid with or without other vitamins, they said the group which received folic acid had a 72% reduction in the incidence of neuron tube defects compared to the group which did not receive folic acid. And this was confirmed by another randomized study in Hungary in 1992. So there was a very definite proof, which was a good randomized studies which showed that folic acid does have a role to play in preventing urine tube defects. Another systematic review, as you increase the folic acid intake per day, the RBC or plasma folate levels keep on increase. So there's a good dose response effect. And if you sort of chart the urine tube defect incidence versus the RBC folate levels. So at low RBC folate levels, the risk, NTD risk is very high, and as you increase the RBC folate levels, the risk reduces till it reaches a plateau at a RBC folate level of about 1000 nanomoles per liter. Is folate fortification effective? So in the US, mandatory fortification with folic acid of all food, staple food, wheat, rice, maize, was authorized in 1996 and fully implemented in 1998. And it has been seen in various situations that after the fortification, the prevalence of folic acid, urine tube defect consistently comes down. And this is a charting of 35 studies from 13 countries where the same effect is seen consistently. The higher the incidence initially, the more the reduction. But a uniform reduction is seen in all cases. But mind you, it does not come back to zero, because there is obviously some other factors which are also responsible. But folate is one of the most important factors which can be taken care of. Now the question is folate fortification on a mass level safe? And there are several concerns. Masking of vitamin B12 deficiencies, there are suspicion of cognitive decline, increased incidence of autism, atherosclerosis, drug interactions, and most importantly, increased cancer risk. And I'll cover these one by one. Now, both folate and vitamin B12 deficiencies can cause megaloblastic anemia. So if the megaloblastic anemia is due to vitamin B12 deficiency only, and you give folic acid, even then the megaloblastic anemia settles down. So you may have a correction of megaloblastic anemia, but because the vitamin B12 levels are still low, the other neurological complications of low vitamin B12 levels can still occur, and this is what is called masking of B12 deficiency. So in countries like ours, where vitamin B12 deficiency is also prevalent, the fortification has to be not only with folic acid, but both of them together. And these are studies which say in the USA, for example, pre and post fortification of folic acid, the incidence of anemia or macrocytic anemia does not increase. There have been suspicion of potential neurological effects with excessive folic acid, and some studies suggested increased risk of dementia. But there are other studies which show that if you give folic acid, the dementia incidence also improves. And at the moment, there is no class 1 data to suggest any adverse neurological deficits because of this. A similar story for autism. This has been put forward by many people saying that no, we should not give folic acid because of the increased risk of autism. So in fact, there are many studies which show that there's a lesser incidence of mental issues or autism if a higher folic acid is given. Again, no evidence, no scientific evidence to prove this. Again, with atherosclerosis, it is known that folic acid reduces the total homocysteine level. This is a well-documented fact. And now there are studies available that the risk of cardiac disease as well as strokes comes down if you supplement with folic acid. Folic acid can interact with antifolate drugs like methotrexate. So in these special situations, you have to be careful with patients who are on chemotherapy or with autoimmune disorders receiving these drugs. It can also interact with anti-seizure medications, so in these special situations one has to be careful. Now coming to carcinogenesis, which is one of the very, very important factors which is preventing this strategy from being employed in India. So folate deficiency causes genome instability and alteration of methylation patterns. So if there is a folate deficiency, then also the risk of oncogenesis is there. On the other hand, if you give elevated folate, then it causes increased synthesis of nucleotides and other metabolites needed for replication. So it can actually increase the risk of carcinogenesis. So there is a dual effect. And the theory of Ulrich is that the timing of exposure is critical. So if you give high folate acid before the existing of a pre-neoplastic cell, it actually reduces the incidence of cancer. Whereas if you give it a high folic acid after the neoplastic cells already exist, then it may promote the cancer growth. So it has a dual, it protects against cancer initiation, but facilitates the growth of pre-neoplastic cells. And there is also the unmetabolized folic acid which circulates in the blood, which has been implicated to have these cancers. And these were the papers which sort of put doubt in people's mind. This was in 1990. This was in 2007. These were the two papers where some doubts had come in. Now, any public health scheme which is done, you have to constantly monitor that there are no side effects. So is there any evidence that increased FA and unmetabolized folic acid have done any harms? And the USA and the UK, they both had constituted authoritative bodies to look into this issue. So this is after 10 to 15 years of fortification worldwide. So the US National Toxicology Program set up an expert panel. They had 4 specific things to look at: cancer, cognition, hypersensitivity related outcomes, and metabolic disorders. And they studied all the literature in this group. And there were 600 papers on folic acid and cancer relationship, and they had 43 pooled and meta-analysis for cancer. And they found that increasing the folic acid does not reduce the incidence of cancer, which is one of the theories that, it could happen. But there is some suggestion that there may be some adverse effects, and therefore they said that there may be specific subgroups which could have increased risk of cancer, and therefore we need further studies. The 2016 UK Scientific Advisory Committee on Nutrition again studied the same things, and they studied the recommendations from other countries also: US, Norway, European Food Safety, the Ireland Food Safety Authority, and the FDA. So they classified all the studies into 4 groups: those with meta-analysis of all available randomized controlled trials, meta-analysis of observational studies, meta-analysis of all studies where the serum and RBC folate levels were considered, and those where the MTHFR, which is the genotype, the methyl tetrahydrolate folate reduction, the enzyme which is involved. And they correlated with prostate cancer, breast cancer, colorectal, and overall cancer risk. And it is with prostate cancer that there was some doubt that the relative risk ratios were higher in some of the studies. In all the others and overall cancer risk, there was no difference at all. And this was their summary. In prostate cancer, giving supplementation does not reduce the risk, and the results from different types of studies are inconsistent. The evidence is inconclusive. In breast cancer, again, there is no association between folic acid and breast cancer risk. Colorectal, again, no beneficial or detrimental effect, and no with overall cancer, the evidence is inconsistent mainly because of the prostate cancer. The other studies from the Norwegian study, the European study, and the Ireland study, they did not find any definite association. And this was a big meta-analysis of 50,000 individuals with cancer, where they said there is no change in the cancer as a result of folic acid supplementation. This graph is the number of colorectal cancer deaths in the USA. And this is when the fortification of breakfast cereals was started in 1973. And despite increased surveillance and colonoscopics in all patients above the age of 50 or 60 years, the mortality has continued to fall. And this is when the fortification was started in 1998. So the epidemiological data does not support the thing that it can cause cancer. Similarly for unmetabolized folic acid. When the folic acid is absorbed by the body, the enzyme actually converts it, and that enzyme is easily saturated. So if you give excessive folic acid, you get unmetabolized folic acid in the blood. And this was thought to be associated with cancer, but study after study says that this free folic acid or unmetabolized folic acid does not cause cancer. So the safety of folic acid fortification has been amply studied by many countries and no cause has been found. So what is the tolerable upper limit of folic acid? There is not enough evidence to say at what level there is no side effect. So what they use is the lowest observed adverse effect level. So this is the lowest level at which some unmasking of vitamin B12 deficiency would be found. And this was found to be 5 milligrams per day. And this is divided by an uncertainty factor of 5 to get a tolerable upper limit, which is 1 milligram per day or 1000 micrograms per day. And this has been established by many, the US Institute of Medicine, the EU Scientific Committee on Food, the UK expert group of vitamins and this thing. If you give higher levels, or even if you give this levels, the serum levels of folic acid will get high. But it's a water-soluble vitamin, and most of it will be sort of excreted in the urine. So even at intakes of 15,000 or 100,000 micrograms per day, the toxicities are not really seen. And what we are, the safe tolerable upper limit is 1,000 micrograms per day. So what are the benefits if you do folic acid fortification? There's a reduced incidence of neuron tube defects. Even in those where it occurs, they are not as severe. The first year survival improves, and the costing, there are major economic benefits. And the side effects practically nil. What are the unintended benefits? There's a reduction in homocysteine levels, and there are meta-analysis to show that there's a decreased risk of stroke as well as stroke mortality. And in fact, there are now evidence to show that it protects against cognitive impairment and a significant association with preventing depression. And of course, anemia we all know about. So for any public health interventions, this is Sir Austin Bradford Hill has published criteria as to what should be done for any public health supplementation. And the food fortification for reduction in NTDs fulfills all of his criteria. So is it cost effective? When there's a patient with a neuron tube defect, there are direct medical costs of treatment. There are direct non-medical costs like developmental services, special education, and there are lifetime indirect costs which we often ignore. These are reduced productivity of the patient, a premature mortality, and most importantly, the caregiver's time and energy spent in looking after these, and loss of function. So it has been calculated that the total economic cost of one patient in spina bifida in the US in 2002 was over $600,000. And this is how much healthcare saving has happened over in various countries. And the cost-benefit ratio is something like 1:48. That means for every $1 you spend on fortification, you save about $48 in the direct cost to the country. So the estimated cost per death averted is only $950. Estimated cost per disability adjusted life year averted is $15. And so the cost effectiveness is very, very good, comparable to what we get for other many vaccines. And it's not just the economic cost, it's the psychosocial impact on the family. And there are studies after studies which tell us about how it affects the psychosocial situation in the family. So what are the WHO guidelines and recommendations? So they have said that if the RBC folate levels are less than 340, which is called deficiency, the risk of neuron tube defects is 50 to 60 per 10,000 or 5 to 6 per 1,000. If you give adequate folic acid, which is sufficiency, more than 906, then the risk drops to 0.5 to 0.6 per 1,000 live births. So it's a very significant reduction. But there is an insufficient part in between. So at the population level, the RBC folate concentrations should be more than 906 nanomoles per liter for maximum prevention of NTDs, and this is from the WHO guidelines. They have also given recommendations which are more specific than just guidelines. All women, from the moment they begin trying to conceive until 12 weeks of gestation, should take a folic acid supplement of 400 micrograms of folic acid daily. So this is the recommendation. The figure is 400. Remember, the tolerable upper limit was 1000 microgram. And what is needed is only 40% of that. And this is the recommended daily announced by several authorities. So working towards this, in 2023, a resolution was passed initially by the WHO Executive Board, which was sanctioned and ratified by the full WHO Assembly, saying that micronutrient deficiencies should be prevented by appropriate folic acid supplementation. India voted for this resolution and is committed to this. Now, based on this recommendation, the WHO, Food and Agricultural Organization, UNICEF, the Global Alliance for Improved Nutrition, Nutrition International, and the Folate Fortification Initiative, they came together and gave guidelines. Now, how much to fortify depends on how much intake is there per day. So at different intake of flours, they have specified how much to fortify. And based on this, the Indian diet, we consume 150 to 300 grams per day of wheat or rice or some staples. So based on this, the fortification should be 1300 micrograms per kg. Now, what is the global scenario? As I mentioned, in 1998, the mandatory folate fortification was done in the US. Canada followed immediately, and most of South America and South Africa followed. Europe has not followed fully. They recommend it but have not made it mandatory, unlike these other countries. And we know that there is a difference between the high-income countries and low-income countries, and with adequate fortification, the prevalence drops to as low as 0.5 per 1,000 live births. Remember, in India it is anywhere between 5 to 9.6. And more benefit is seen where the initial prevalence is high, and India has a high prevalence as per the literature. So at the moment, the countries in green are where the mandatory folic acid fortification is there, and Nepal surprisingly has it, but unfortunately we don't have that in India. So more than 80 countries have implemented mandatory folic acid fortification, resulting in a consistent and significant reduction in the incidence of spina bifida. And this has been there for more than 25 years. And not one country which has this mandatory fortification has reversed this policy or seen side effects which would mandate reversal of this policy. So where does India stand? In India, we have 120,000 births every year with neuron tube defects, which is a huge number. We are not counting the stillbirths or people who, with fetuses who are so abnormal that they do not even come. Is vitamin B12 and folic acid insufficiency common in India? And there are studies from Haryana, Maharashtra, South India, where the RBC folate levels, vitamin B12 deficiencies, both of them are rampant. So there is a problem. And what has our government done? So they have instituted folic acid supplementation programs. Now we have to differentiate between supplementation and fortification. Supplementation is where you give extra drug to a selected group. So they distribute folic acid tablet to all pregnant women. This is a national policy. But by the time they distribute and the lady knows she is pregnant, the damage is already done. So this is effectively useless. It can help in anemia, it will not help in urine tube defects. So to counter this, they said, okay, let us give these folic acid tablets to every woman in the reproductive age group. So through the ASHA workers, they started this program when this first part was told to them. So what they do is these ASHA workers go to the villages. Any girl above 16 is given a packet of pills to be consumed daily. Now this, if it works, would be very good. But unfortunately, the compliance is extremely, extremely poor. There is enough data to show that these young girls, they take these packets and throw them in the dustbin. Hardly anybody uses them. And anyway, even if they know the significance of it, they should start taking it for at least 3 months before their pregnancy. But more than 50% of pregnancies in India and elsewhere are unplanned. So there is no way you can start it before you want to become pregnant. Because the adequate folate levels are needed in the blood, in the mother's blood before and during early pregnancy if you want to avoid these problems. So it is well proven worldwide that supplementation does not work. So what is the solution? Fortification of staple food, of all the food, and it has to be mandatory. It has to reach all women of reproductive age group equitably, effectively, inexpensively, and at the right time. And it is technically easy to do. All foods can be supplemented. It is safe, it is cost effective, and a major byproduct would be it will reduce the incidence of nutritional anemia in the whole population. You can use it for rice, you can use it for wheat, for maize, you can put it in tea or coffee, you can supplement it in oil, and what we prefer is that you can supplement it in soil and salt. Because there are rice eaters and wheat eaters. There are coffee drinkers and tea drinkers. And there are some who don't drink either of them, they have other choices. But salt is something universally everybody takes. The other major advantage of salt is that it is such a low-cost product. It's not something that people make super profits. So nobody wants to make salt on a smaller level. You know, you have the roadside chakki wala who will make your flour. So to have implementation throughout the country, you know, there are so many players in the staples food that is not going to be easy. But salt is made only by the Tatas and the Birlas and the big groups. And therefore you can have implementation of your fortification much better. So unique acids of folic acid fortification, usually nutrient fortification is done to correct a nutrient deficiency. And here we are doing it to prevent a disease. And it exposes the whole population to fortification, even the others, but is intended only for a narrow segment. And the choice of fortification agent is not the dietary folate, which is not very stable, but a synthetic compound folic acid, which is much more stable with cooking. And it gets reduced to dihydrofolate reductase by this enzyme to naturally reduced forms, which are the active forms. So we have to remember the precautionary principle. Because you have fortification, the food of everybody, the potential health gains for some should not come at a health cost to others. So the FSSAI, which controls the fortification or the levels of recommended allowances, in 2016 the recommendations were in consonance with the WHO and the World Guidelines. But in 2018, they reduced it to 1/10 of the original. Why did they do it? They said our mandate is only to prevent anemia and not neural tube defects. And as a result of this reduction, this is where India stands at the bottom of the pile in the levels of recommendation. What have we done? The Indian Society of Pediatric Neurosurgery joined hands with the Neurological Society of India and some pediatricians from AIIMS and other like-minded people to try to convince the government to correct this anomaly. We have had several meetings with FSSAI requesting them to increase the recommended levels. We made detailed presentations to the expert committee. We've approached the government officials, the union health minister. We've had somebody ask a question in the Rajya Sabha also. And they have shared these concerns with us, the FSSAI. And they have given their observations that anemia is our only concern. NTD is not a big problem in India. And, we can only increase the folic acid or any nutrient up to 50% of RDA. And the RDA for the recommended is 300 micrograms. What we are asking for is 400. And the nutritionists in the group always raise the bogey of cancer based on theoretical risks. So the same thing they have said in the Rajya Sabha. And there has actually been a fortification demo project done in 2016 to 19 by PGI Chandigarh and the WHO, which shows that if you actually fortify, so this is the proof of the pudding. There is a reduction in anemia in 20%, reduction in severe anemia by 33%, folate deficiency 50%, RBC folate deficiency is improved by 87%, vitamin B12 deficiency is improved by 64%. So if you actually do it, a pilot project has already been done and it works. So our efforts have not been successful because they say the mandate is not to treat NTD. That's too small a number for them to consider. And they have the safety concerns, the theoretical risk of carcinogenesis. So after the failure to convince FSSAI, we escalated the matter to ICMR to assess the safety. So they have constituted an expert panel of more than 25 people from all over the country to try to talk about safety of folic acid fortification. We have made presentations to them. We are still actively engaged with them. And their concern of Dr. Bahl, who's the ICMR director, is what if it causes carcinogenesis? He says the incidence of cancer is increasing in India, and what if we are accused that it is because of the folic acid that we are doing? So we've told them about the tolerable upper limit. We've told them about the worldwide exposure, where 80 countries have been doing it for more than 25 years with monitoring and nothing has happened. And several countries give much more than what we give, what we are proposing, and still no side effects are seen. The second concern is how can we give it to the whole population when the population at risk is only a very small one? And our response is that the similar thing has been done with iodine. Universal iodization of salt has been a government policy. And all these countries in yellow are the ones where they have fortified iodine fortification. There also the population at risk is small. It's not everybody doesn't have goiter or iodine deficiency. But the consequences are so much that we should do it. So it is a proven and cost-effective intervention, folic acid fortification, and it is one of the most successful public health initiatives. It is one of the greatest success stories, and it is something, a disease which is primarily preventable to a large degree by the simple measure. And from a public health perspective, the high prevalence in countries like ours without fortification is like not preventing an epidemic. So there's a moral obligation also. And this skepticism and inaction has cost thousands of lives. It causes suffering to patients and families, provides an avoidable burden on the healthcare systems. So what can we do? And this is my appeal to all of you. As neurosurgeons, as neurologists, as pediatricians, we are the ones who see the suffering of these children and families. It's a lifetime of suffering. You cannot cure them. You're always firefighting. They get kidney problems, they have infections, and you're always trying to get them back to the basal level. And the thing is, prevention, for 30 years we know how to prevent this. And it is easy, it is safe, it is cost effective. And that we allow this to still happen is not acceptable. It is a moral obligation to rise to the occasion and try to convince the government. I know this is not neurosurgery, but because we see these patients, I think it's a moral obligation to take part in it. And we have to take the lead, we have to be the champions, we have to spread awareness in the society, and we have to cajole the government agencies to help these unfortunate kids. And so we need to do this, these children with a lifetime of suffering, and with the families spending so much money and the burden on the healthcare system, if we can take this mission forward, these children would be eternally grateful. Thank you very much for your attention.
Thank you very much, sir, for enlightening us. It was inspiring and both learning. Sir, Jayanji, are you ready? Sir, we request Khosla sir, Yadav sir, Kapoor sir, Dean sir to come forward and felicitate our orator. I request Dean sir and Yadav sir to felicitate Professor Khosla sir. Thank you very much, sir. I request Ratra sir to give vote of thanks.
Respected dignitaries, I place my sincere gratitude to Professor Navni Saxena sir, Dean of our NSCV Medical College Jabalpur, for her valuable presence and sparing time for us. We are thankful to Professor Abdush Kumar, Director Super Specialty Hospital. We are very thankful to Professor V.K. Khosla sir and Madam for their gracious presence and blessing to all of us. We are thankful to our orator, respected Professor V.P. Singh sir, for enlightening us on the important topic. We are thankful to our teacher, Professor Kapoor sir, for always guiding us. We are thankful to all the guest faculties for their gracious presence. We are thankful to Professor Y.R. Yadav sir, who is the soul of this fellowship and always there to teach us and guide us. We are thankful to Dr. Jiten Gupta, Superintendent of our Super Specialty Hospital. We are very thankful to Professor Arjun Saxena sir, Head of the Department Surgery, Sukhsagar Medical College. We are thankful to Dr. Ashish Tandon sir and all the Neuro Club members. We are thankful to Professor Aparna Madam, the Head of Department of Neuroanesthesia, for always helping us. And we are thankful to our Anatomy Department. We are thankful to all the delegates. And I am thankful to whole of the neurosurgery department, all the staff, OT staff, OPD workers, all the workers. And I am thankful to Carl Stores and Intar. Thank you very much, and you are all welcome for lunch.